subluxation, bringing that into a clinical problem. Those ones you can manipulate, but always manipulate into flexion. Never ever manipulate into extension under those circumstances. Don't manipulate if it's going to produce a spasm or an MTN feel. Just don't do it. All right, it's an adverse joint environment. You're going to make it worse. An MTN feel is always an indication of severe pathology anyway. Bilateral pain. Give a lot of thought to that. Probably at this stage, don't manipulate somebody with bilateral pain, arm pain or leg pain, or going around the chest. These tend to be more central rather than peripheral. So what you're really thinking about, it could be bilateral lateral stenosis. And if you're sure that's what it is, and it's a clinical an episodic stenosis, which I've never ever seen bilaterally, then you can manipulate it. But otherwise, I would stay away from this. Also, don't manipulate if there's systemic arthropathy or any disease that you don't understand, all right? If they've got a systemic disease that you don't know about, check it out first, research it, and then if it's okay to manipulate on top of that, then do so. Give me a minute, will you? Sorry. Got it? Sorry. Now, what you see I've left out here is pain on a pre-manip hold. I don't think that that's a contraindication of manipulating. It depends on what the symptoms are. What it does mean, though, is you need to try and find a different way of manipulating that doesn't produce that pain. The original intent of the pre-manip hold was to produce dizziness in the neck. And the argument there was if it's producing dizziness, then don't manipulate it. I want to worry about the dizziness. I'm not even sure that's necessarily a contraindication neither. If positioning, holding the spine in that position is painful, you're gonna find it's not a comfortable nip at about 25-30% of the manips anyway. And post-manip soreness is not unavoidable. This not manipulating into the painful range will tend to avoid post-manip soreness, but post-manip soreness isn't that major problem. What you've got to make sure you do with a patient, though, is tell them they're gonna be sore after it's been manipulated. Now, most of them won't be. When I say I wasn't sore, I say, oh, well, you're obviously a man or a real woman. Bullshit them, but tell them they're going to be sore and then they won't get panicky about it if they are, all right? But try and find a different way of doing it. You've got at least a couple of manipulations for each joint. So try and find another way of doing it. If you can't, manipulate it, and they're going to have to live with a post-manip soreness. But if it's producing dizziness, you should be able to produce the same dizziness by non-movement stressing of the segment. Transverse shear, something that doesn't move the neck or put it into an abnormal position. If you can't do that, if stressing it doesn't produce pain that then links with the dizziness, don't do the manip. If the pre-manip holds producing dizziness, you can't produce by non-movement stressing of the segment, don't manipulate it. Find out what the dizziness is from. That may well be VBI. Is that okay? Dave, Eric, do you have a problem with that?
No, not at all. I think most of the time when we talked about pre-manip holds, we were talking about what could go wrong with the manipulation. For instance, if you do a technique and you take them into position that you may not want them to get into, but the technique is lent to that sort of direction. So a lot of the times when we were discussing those sort of things, it was like, okay, if I don't do this technique properly, what could happen as far as positioning of the neck? Right. So that was another thing that we discussed with the pre-manip hold.
Yeah, that's reasonable. If you can find a different way of doing them, then you probably should do so. If you can't, I mean, basically, you're either going to manipulate or not, and it's your choice and the patient's choice. But just warn them you're going to be likely to be sore afterwards. When they're not, everybody's happy. You okay with that, Dave?
Yeah, and that's what somebody was asking earlier this week about, hey, going over a little bit of, what is the safety exam or what would be considered the safety issues? And I think this is kind of for the cervical spine and largely the lumbar spine as well. Pretty clearly the things that you think of, okay, what are the terrible things that could happen or that I could miss? It's in these.
Yeah.
That biomechanical dysfunction and MTN feels. Yeah. Like that's right away, a manipulable lesion.
Would you look at If this is based mostly on, you said this was based on the neck, on the cervical spine, correct?
No, that's actually fairly general. I'm going to look at the
General.
neck now.
Okay.
But that's pretty general, I think. Come on, move it. There we go. So this is cervical spine. Again, like there's a lot of overlap. So I'm gonna, if I repeat them, it's worth repeating. Don't manipulate if it's not a biomechanical dysfunction. Don't manipulate if there's a fracture or dislocation. Don't manipulate if there's undiagnosed dizziness. All right. Undiagnosed dizziness is a contraindication to manipulating. So if the doctor hasn't diagnosed it, you need to. And if you can't diagnose it, don't manipulate. Is that all right? Don't manipulate if dizziness is coupled with headache and both of them are uncoupled from neck pain. I think this is about the worst combination you can get. There isn't much else that's going to do this other than VBI. The same source is causing headache and dizziness, but it's not causing a neck pain. You really don't want to be messing with that one. You need to find out exactly what that is. I think that coupling there actually precludes range of motion exam as well, personally. It's a very unusual coupling, but it isn't a good one. You okay with that? Undiagnosed dizziness that cannot be reproduced from the no movement segmental stress test. So if you're doing transverse shears, if it's reproducing pain, but it doesn't reproduce dizziness, then you need to be really on your toes about that. Now that dizziness may come on later on. Same with a headache, actually. If you like, they're referred symptoms, and they may come on later on, or you may not have stressed it enough. But be really careful. If you can't produce their dizziness, their other symptoms from stressing the neck, then you have to wonder if those symptoms are coming from the neck. All right. That can also be a false positive, though, because if you're not stressing it enough, you're not going to get the headache and dizziness. Premandibular hold that reproduces dizziness when non-movement segmental stress tests don't. We just talked about that one. There is undiagnosed neurological signs and symptoms. We just talked about that. Cranial nerve exam is positive. Now, I don't think it matters whether this is caused by VBI or anything else. If you have a cranial nerve exam, you have a central lesion going on there. That needs to be sorted out before you do anything else to that patient. Everything you do may be perfectly safe, but that doesn't mean to say their condition is safe. If they've got a bleed into the brainstem or something like that, it may only show up on the exam, the objective signs. So you need to take notice of that and get it sorted out by the physician. All right. This could be potentially very, very nasty. Right. Don't go any further than that. Don't manipulate if a sharp person test is positive, certainly at your stage. There's a reason why the sharp person test is positive. And it is because there's an instability at C1-2. Now, if you're manipulating C4-5, we're telling not to lock through the neck. So you're not stressing the AA joint, but you have to wonder why that's unstable. Is this part of a central or a systemic arthropathy that's making this unstable? So just hold back, find out exactly what's going on before you start manipulating the neck. You have no idea what's happening in that neck. Minimized decline test is positive for undiagnosed pathology. Okay, so if you've gone through all of this stuff and you put them in minimized decline and it still makes them dizzy, now I'm going to count that as a positive, and you've got no indication they should be dizzy, either that's not part of their symptomatology, or you've gone through everything, you decided the dizziness was okay. But if you haven't done all that, and this is just popping up in the minimized decline test, then I would hold off and find out exactly what's causing it. Again, same as before, if there's a systemic arthropathy or any other disease that you don't understand, find out about it first. Now, remember that systemic arthropathies tend to be collagen weakening diseases. These people tend to have fragile collagen. So you might think, okay, well, they got anchispon, well, not anchispon, because that's a contraindication to everything here, but you may think they've got arthritis that isn't affecting the neck. The collagen may still be weak in the neck. You don't know, right? So you've got lots of other things you can do rather than manipulate them. Right? Find out what their problem is before you start jumping all over them. Anybody got any questions about that? It looks like a big list, but it's actually not. None of these things generally turn up. If you find any of these, you should be sitting back going, what the hell is going on here? So it's not like there's a lot of things that's going to stop you from manipulating, but these are the sort of things from the examination that should give you pause at the very least. Okay. And it's not a special exam or anything. You're gaining this from the whole examination, and then you do special tests afterwards. If you want to do the minimized decline test as a screening test, you've already asked them about the dizziness. You've asked them about their other symptoms. You already found that stuff out. So you decided there isn't a VBI problem. You do the decline test because you're pretty damn sure it isn't a VBI problem. That turns out to be negative. Everything that's gone before it is negative. You can now do the manipulation. So it's not like there's a whole bunch of tests you have to do right immediately before you do the manip. This all comes out of the exam. Okay. All right. So, you got one of your fellows there, Dave?
I do.
Can I have one of them?
Or let me go to the offering plate. They're all jumping off right now, so I had to catch them real quick. Drew's always there. Drew's like the whipping boy of fellowship.
Yeah, I'm here.
Who dat?
Drew.
Sorry, I missed it.
This is Drew.
Okay, Drew. All right, mate. I just want to make an example of this and just see where we're going with this. So we've got a 38-year-old female post-MBA, rear-ended a month earlier. Is managed with the MD by analgesics and rest. She's complaining of pain in the right upper neck, right suboccipital and occipital area, both sharp pain and aching. Neither is progressing. She has lightheadedness. All right. The onset of severe pain on waking next morning was the pain was the next morning. The lightheadedness came on later that day. Not progressing or improving. Pain worse AM and on prolonged positioning, such as driving and watching TV. The ache is with positioning. The sharp pain is with unguarded movement. Okay. So what I want you to tell me is, what are you thinking at the moment? Where's your brain with this?
I want to know what the she have the lightheadedness, and I want to connect neck pain with lightheadedness.
Okay. How would the neck cause the lightheadedness? What's the mechanism for that? Do you understand the question?
Right. So the lightheadedness to me, the neck wouldn't necessarily cause. So I guess I'm not connecting. I'm making sure they're not connected.
Why wouldn't the neck cause lightheadedness? Why do you think it wouldn't do that? Can the cervical spine cause dizziness?
Yeah.
Okay, lightheadedness is dizziness.
Okay.
So what's the mechanism for the neck causing dizziness? The neck itself now, I mean the musculoskeletal aspects of it.
My understanding is from the trigeminal facilitation, the upper cervical spine, C1, 2, 3, can have the effect of causing dizziness with irritation of that trigeminal nerve, or yeah,
How?
trigeminal.
How? Let me do it slightly differently. What are the inputs into your balance system? Major inputs.
Proprioception, is that what, like proprioception? Is that what
Yeah.
you're asking?
Particularly from the upper neck. Yeah.
Particularly from what?
The upper neck.
Okay. Head position,
Yeah,
that's different than proprioception. Um, Eyesight,
yeah,
vestibular.
yeah.
I'm missing anything here?
Well, yeah, the vision does it, but also the position of the eyeballs does it as well.
Okay.
Yeah.
And then that's different than head position?
Yeah.
Okay.
Yeah. I can move my eyes, or I can keep the eyes still when I move the head. So the extraocular muscles have to have a huge input into this, and they do. So how will a problem in the neck cause dizziness?
So if it changes the proprioception, or if it's mechanical and physically changes the position of the head
That's
or
what
neck.
comes out of proprioception. If you think about it in these terms, balance of imbalance, dizziness in particular, is a conflict between the systems. One system or more is not having an appropriate input. And this is what causes the symptom of dizziness, or it's one cause of dizziness. So if the neck is dysfunctional, its proprioceptive input is abnormal, and that can lead to dizziness. It's actually got very little to do with the trigeminal nerve, other than these impulses go through the trigeminal nerve. Yeah, but it's not really about facilitation of the nerve. Not directly. The facilitation causes hypertonicity of the suboccipital muscles, which can then alter their input as well. But ultimately, it comes down to proprioceptive screw up in the neck. Same as if you close your eyes. You close your eyes, your balance isn't as good. If you stand on one leg, close your eyes, you're more likely to fall over with the eyes closed than if they're open. So you've lost one system, the whole balance system fall, well, it doesn't fall to pieces necessarily, but it takes a lot more accommodating. Yeah?
Yeah.
Okay, so do you want the dizziness linked with the neck pain?
Yes.
Yeah, okay. All right, carry on from there. So how are you going to sort out whether the dizziness is linked with the neck or not?
If I can move the joints of the neck and reproduce the dizziness.
Okay, what else could be causing dizziness?
Could be VBI.
Okay, do you really want to move the neck around until you know it's not VBI?
No.
Okay, so where are you going with this?
Do a cranial nerve exam.
Okay, if they haven't got symptoms, how likely is the cranial nerve exam to be positive?
Probably not very likely without symptoms.
Yeah, because it's a transient issue. If it is VBI, it's going to be transient. So you can't take a negative exam as being a true negative, yeah, for VBI, for example. Yeah.
Mhm.
So where'd you go to? If you look at
We go with
the case I've given
body
you
rotation.
here, if you think about what we just talked about with the contraindicators manipulating, in this patient, this is post-trauma. What's your 3-4 major concerns with this patient right now? There's 3 concerns.
Potential fracture.
Yeah. Does she have that?
Is she not
Does she have
willing to move?
Sorry?
Is she not willing to move?
You're not asking her to move, are you? Do you really want to
Well,
move
that-
it if she's got a fracture?
No, that's what I'm
No.
observing.
No, you
her
can't observe
willingness
if they're not
to
moving.
move.
You don't know whether they want to or not. You've got enough information there to tell me the probability of a fracture is high or low. Have a look at their symptoms. The rest of you do the same as well. You should be working your way through this.
You're asking, like, based on her symptoms, if there was a fracture, would it be high or low?
Yeah.
Is that what you're saying?
No, sorry. The risk of a fracture, is it high or low based on her symptoms? The risk of it.
Low.
Why?
It's not progressively getting worse, and
Well, fractures don't. Not unless you jump up and down.
the majority of the pain is, well, she has sharp pain and aching, but it doesn't appear that it is.
All right, with a fracture, would you expect the onset of severe pain to be immediate or delayed?
Immediate.
What have we got?
Delayed. It's the next morning. So
Yeah,
I would say
so it's
that's delayed.
unlikely to be a fracture, is it?
Right.
Okay. All right, so that's one thing we can not rule out, but we can breathe a bit easier about. What's your next concern here?
Upper cervical instability.
Okay, so is there any indication that's the case?
No, not from what I'm given.
Okay, there's no mention of a deformity, which is generally what happens with an upper cervical
Right.
dislocation or partial dislocation. And again, the onset was delayed, so it's unlikely there's a fracture or a dislocation present, yeah?
Right.
Next, what's your next concern?
Still be concerned with ruling out VBI.
Yeah, so look, this is about processing now. Instead of going straight to a symptom like dizziness, look at the patient who's coming in, the context around that patient, and say, what am I mainly concerned about here? If they walk in and go, okay, no, I know there's no trauma, I've had this pain before, then you're not worried about too many things, are you? You're thinking it's a biomechanical dysfunction straight off the bat. But with this type of patient, if you think about what areas concern you with this type of patient, and group them in categories: fracture, fracture dislocation, VBI. Okay, they're your main concerns. And then go from there, rather than pick out an individual symptom, and then you get bogged down in the detail of that symptom and you never get out of it. Okay,
Okay.
it doesn't work. You stay with that symptom and everything sort of orbits around it. So big categories, work your way down to it. Okay, so what we got to do is, first off, what's the chances of her having VBI? I'm not talking about probability in terms of incidence and populations now, but given the symptoms, are the chances of her having VBI higher or lower than a fracture in this case?
Higher or lower than a fracture?
Yeah,
Lower.
why?
Honestly, I don't know
Okay,
how
Well,
I would differentiate what's more likely between the fracture and the VBI.
in this particular patient, does this particular patient have any symptoms that could be ascribed to a fracture or a dislocation? You've already told me, tell me again.
No.
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 Does she have any symptoms that could be ascribed to VBI?
Yes.
She's got dizziness and headache. Yeah?
Yeah.
So which is the higher risk, VBI or a fracture?
So VBI would be a higher risk.
Yeah. So sort your way through that. How are you going to do this? And I'm going to put a proviso on this. Don't move the patient's neck. You've done a cranial nerve exam, that was negative.
So do like a shoulder rotation. You're not moving the
Now you're still moving
head,
the
but
neck.
rotate.
Now you're moving the neck. You're just moving it from the bottom up rather than the top down. This is history. This is all subjective. You've got the symptoms there. Work your way through the symptoms.
So does the lightheadedness come on with neck pain?
Okay, all right, so you're going to try and couple and uncouple them.
Okay.
Does the lightheadedness come on with neck pain? Not always. I can have neck pain and no lightheadedness.
Okay, how about the headache? With the
Again, I
lightheadedness.
can have the neck pain without the headache.
Can you have the headache without the lightheadedness?
No, they always tend to be together.
Okay. So it sounds like the lightheadedness and the headache are coupled and not necessarily coupled with the neck pain.
Well, that's the word, isn't it? Necessarily. When would they come on in response to the neck pain?
Like positionally?
No,
Like when,
no.
what do you mean?
All right, is referred pain likely to come on when the local pain is more or less severe?
More.
Okay, so there's your question, isn't it? You haven't uncoupled them, you just uncoupled them from possibly from mild pain. She said it's not always together. The question is, okay, in that case, when your neck's bad, do you always get those two symptoms?
Okay.
And that's your question. That's your follow-up question, saying, is the neck pain always, is the headache and dizziness always present when the neck pain is present? No, it's not. What about when your neck pain is severe? Do they always come on? Okay.
Okay.
All right. The answer to that is, yeah, pretty much.
Every time it's severe, then you get the head and the neck pain.
Pretty much, yeah. Understand you've got a patient here who's not going to give you nice, clear answers like I am.
Right.
So have you got a conclusion or not?
I would feel comfortable at that point that the neck pain is coupled to the headache and the dizziness. If it's a
Okay, what
severe neck
about
pain,
if
then
she's got two different lesions here? One is BVI. She has an injury to the artery. And she's also got dizziness caused from the neck, and the headache caused from the neck and from the artery. Now what?
then you would have to differentiate between the two of those, and I'm guessing we still can't move the head.
Yeah, no, you can't.
I don't know. I don't know if I'm gonna be able to. What, like I'm at a loss with that. Like, how are you gonna differentiate between the two of them?
It's difficult, and that's the point of this. You can never say, I'm happy that that they are all to do with the neck. You just can't say that. Now you can start thinking about more testing. You can start looking at, and you should have probably done this earlier, take the pulses in the carotids and seeing if you get a differential from side to side, which would indicate an occlusion of one artery, which may or may not be useful. You also want to ask them about positioning. Is it like, does the dizziness come on when you're just sitting watching TV, or do you have to have your neck in an awkward position? So you have to really dig into this. This is a matter of, are they getting better at the same time? Are they getting worse at the same time? There's a whole bunch of questions that you have to ask to completely couple or uncouple the symptoms. A simple 3 or 4 questions, the way we just did it here, isn't enough in this case. It's certainly enough if the patient says, I have neck pain and I have lots of neck pain, but I have the headache and dizziness intermittently, and it doesn't seem to be related to the intensity of the neck pain. Then you can say, okay, get the hell out of my clinic. But this, you can't say for certain one or another, and you have to dig a lot more. So you're looking for coupling questions, and you're going to have to work your way through those. How do you couple it? Do they start at the same time? Do they go off at the same time? Is the neck pain improving? Are they improving? Is the neck pain getting worse? Are they getting worse? Okay, so this becomes much more complicated when you don't get nice, clear answers. All right, but given all that, then you can start thinking about objective testing. So where do you want to go with your objective testing?
I want to go with physiological movement.
Well,
Range of
think about
motion.
it. Movement is possibly the most dangerous thing you're going to do to them. Is there any other way you can stress the neck without moving it?
Without
No?
Um,
We were just talking about it. No movement stress tests. You can do transverse shears. You can even do PAs, although that will give you a bit more movement. What you've got to try and do is produce pain and then see if that brings on these symptoms or not.
what was the first one you said? You cut out there. The first thing you can do.
Transverse shears. As long as the neck doesn't
Okay.
move, you can still hurt the neck.
You can.
Or
Okay.
pain. But that's safer than moving the neck. If that's producing dizziness, okay, the simple act of stressing the neck, then maybe you can start thinking about moving the neck. But while they're dizzy, what are you going to do if you make them dizzy from stressing the neck? What's the next move?
The cranial nerve exam.
Yeah, good. So if the cranial nerve exam is negative, you can start moving on to a minimized decline, progressive minimized decline. Yeah.
Okay. Yeah.
Um,
Because there's still you're saying there's still the chance that there's BBI is just much less now because they were experiencing the dizziness and had a negative cranial nerve exam.
yeah, I mean, basically, what we've done here is you never say that there's no chance of anything, all right? Ever.
Okay.
There's no chance of this. This is absolutely what it is. It isn't the way the body works. We make approximations of the body when we're doing this stuff, not detailed. Individuals are different. That's why drugs work differently on different people. People are different. So what you've done here is you've failed to uncouple the three symptoms, but you have coupled them in effect. You've coupled all three together, which isn't ideal. Ideally, what you want to do is decouple the headache and the dizziness and link one of them to the neck and then worry about the other one. That's ideal. You've also made them dizzy without moving the neck with a negative cranial nerve exam. So you've got about as much as you can do. You stress the neck, you produce the pain, and the cranial nerve exam is negative. And you've also caused a headache, presumably. And all those three things have failed to produce a positive cranial nerve exam. Now you can move on to moving them. Is that okay?
Yeah. So then do you still start with the modified declines before you put your hands on them and
No. I mean, no.
start moving?
As soon as you get them to move into positions, whether you've touched them or not, they're moving into those positions. You're responsible for telling them I know one of the arguments here, don't touch them because if they have a stroke, you haven't touched them. That's complete and utter bullshit. You've told them the position to move their neck into and they've done what you told them to. That's no different from you actually moving the neck into that position. If you're going to put your hands onto them, you don't move the neck with your hands initially. Stress it. Stress the neck without moving the neck. And then you can move them into the positions you want them to move into. Is that okay?
Yeah, no, that's perfect. So then you can.
Okay, so we go through declines.
Yep.
And that doesn't produce any dizziness. Yeah, let's give you that way. It doesn't produce any dizziness. Now what?
Now I would feel comfortable testing the biomechanics of the neck.
Yeah, you should be comfortable now. You've basically put them into 4 quadrants.
Yeah.
So you should be comfortable enough about doing a regular exam, except you've still got a couple of tests to do here. What are they? before you think about a normal exam. In fact, it'd probably been a good idea to have done this before you did the minimizing decline. Sharp Purser,
Okay, so like an upper cranial
yeah,
stability. Okay.
yeah. Okay, then if you're all right with that, you're okay, there's no fracture dislocations, no instabilities, then you can start your routine exam.
Okay.
Is that okay?
Yep.
All righty. Anybody got any questions or anything to add there? No? Okay. Okay, so just to review that, your major concerns on this particular patient is a serious fracture. No, the pain was delayed, but check the C-spine rule as well. Is there an intracranial bleed? No, there was no progression of the headache, but check for gravity-dependent sensitivity. VBI, maybe there is headache and dizziness. Conclusion, do not manipulate until you diagnose the headache and the dizziness. Okay, and you've got to be careful how you go about diagnosing the dizziness. You just shouldn't just get hold of them and start moving them around. Okay. Now, if you're wondering why I haven't mentioned the alar ligament, it's because this is about life-threatening stuff, and the alar ligament isn't life-threatening. If they've got severe upper cervical pain unilaterally with a sudden onset, then an alar ligament tear is one of the things it could be. But let's assume that's not the case. We've got an onset of delayed pain, as it was in this case. So I'm not worried about the alar ligament, just not worried about it. Even if there is an instability of the alar ligament, you're not going to, well, even if you manipulate that segment and you do it right, you're pushing a subluxation. So you're not going to overstress the alar ligament anyway. So I'm not worried about the alar ligament as a life-threatening thing. You okay with that? But if you want to do it, I would strongly suggest you don't use the stress test in this particular patient. Use the kinetic test where you palpate, we talked about this last time, where you palpate the C2 spinous process, side bend the head around an axis, very small axis, for the rear of the nose, no more than that, and you're feeling it. You should feel an immediate movement of the spinous process. It's not definitive as the stress test is, but for these purposes it will do. If you use a stress test on this patient, the high likelihood is you're going to give this patient a vasovagal response. They're going to be sick for days, and you're probably never going to see them again. They're not going to come back to you. A stress test isn't a good idea in this case. I wouldn't do it. I don't know if I ever told you this story or not. Probably not. I saw a patient years ago on consult, and it's a motor vehicle accident 10 years earlier. She was 18 years old at the time. She was just starting university, and she was in a car accident. Severe onset of sudden pain. All of the imaging was negative. Now, this is 20 years ago, at least 20 years ago, and 10 years before that. So we're looking at 30 odd years ago. So the imaging was mostly X-rays in. Even if they'd done an MRI and a CT scan, the weighting for an alar ligament, the weight you put onto the imaging wasn't there anyway. Anyway, everything was negative. And she went to university. She got better from it, went to university, and carrying a bag around with books in it, the whole thing flared up. She had to take some time off. She managed 6 months of university and had to stop. So she went to work instead of going to university. And she never held a job for more about 3 or 4 months because this thing would flare up. She died down and she was out of work, basically. It was always within her probation time so they could fire her, which they did. She went through numerous jobs. And I finally saw her. Now, she had radiofrequency ablations of the nerves, injections to destroy the nerves, all sorts of crap, chiropractic, acupuncture, aromatherapy, pretty much anything you could think of. And I saw her on consult. And I tested the kinetic test and that was negative for the other because it was on one side, it's right up high, very specific area, right underneath the suboccipital region. And I said to her, and I tested the rest of the neck. She had a C4-5 problem, which I had nothing to do with what she was complaining of. I manipulated it anyway, didn't make any difference. And so I said, I want to stress this, but it's not going to do, you're not going to be happy with this. And I stressed it, very positive, immediate onset of the pain she complained of. And she was ill. She phoned me up the next day and she said, I'm in bed, I'm sick, I'm vomiting. She said, but that's okay. She said, I'm sort of used to this. And I said, well, okay, just stay in touch. I'll see you when you're feeling better. She did, she came in. And there was an article just came out by a group of radiologists. Radnoff was one of them. And they've just done a radio imaging study. And their recommendation was when you identify a alar ligament tear, was to immobilize it, hard collar for at least 8 to 12 weeks. So her doctor was actually doing some consults from the clinic I was doing consults in. And I went over and chatted to her about putting her in a collar. And she's had all this stuff done to her, injections, all sorts of stuff. And she went, that is so drastic, a collar. Oh, for God's sake. I said, have a look at what's happened to her in the last 10 years and tell me how drastic it is. So, all right, I see your point. We put her in a collar, and as soon as it was a Philadelphia collar, as soon as the collar went on, she went, oh, that is so much better. So I said, okay, leave it on. She got two, one of wearing the shower. She take it off, wash her neck, put the collar back on, then wash the other collar. She had this on for 12 weeks, and she said, this is really good. I haven't really had any pain since I put it on. So I said, okay. She said, the only problem is if I put my head back on the car rest and the car's running, she said, the vibrations will give me pain. I went, oh, that can't be bloody good. And we got to 12 weeks. I said, okay, we'll take it off. As soon as I took it off, all the pain came back again. When they're positive, they're very positive. One way you could do it is to manipulate, not me, but you could, if you're brave enough, manipulate the neck to tear the remaining fibers of the alar ligament, because that's got to be a grade 2 tear, and that's the way it felt on the stress test. But they don't pay me enough for that. So what do you do with that? I said, wear the collar, don't wear the collar. I'm sorry, I can't think of anything else for you. And they would start to do some repairs a little bit before that. I'm looking back on some articles on repairing the alar ligament, and they'd stopped doing them. It was too risky and it wasn't working very well. So that's an acute, well, it's an acute alar ligament. They were acute flare-ups of a chronic alar ligament tear, just never got better. So I didn't know what to do with her. Neither did she. But are you okay with those conclusions there from this case? Everybody all right with that? Okay, so one more thing about manipulation. Things to do before the manipulation. And I'm going to talk about things to do after. I should have done. Before and after. Make sure of your diagnosis before you manipulate. Make sure of the contraindications. All the stuff we just talked about, okay? Potential contraindications. Do a proper exam. If you're finding stuff that you're not happy with, find out what it is, either through your clinical exam or research. Warn the patient about post-manip soreness. Tell them, even if, I still do, and I've been manipulating for decades, I still tell them it's going to get sore afterwards. And when it's not, everybody's happy. After you've manipulated, immediately after, do a couple of minutes of PAs over the segment. This is anywhere in the spine. Get some more proprioception, or use muscle stim for about 10 minutes or so. It will maximize the neurophysiological effect. All right. A single manipulation, you'll get rid of most of the neurophysiological effect, but it's fairly reasonably short-lived usually. If you do some more proprioceptive stuff into this, then it will probably last longer. Okay. So either PA, something simple, or wobbles, or stim, or both. Rehab exercises immediately afterwards, and muscle stim for the paravertebrals and multivertebrate. I actually get to buy a machine to use during the treatment and after, because it does delay the onset of the next episode. No doubt about that at all. but they've got to be fairly high stimulation, get the paravertebrals working properly, and hopefully the multiplier work as well. The next time they come in, the first thing you're not concerned with is, are you feeling better from the manipulation? It's more, what's happened since the manipulation? Okay, you've got to make sure they have no potential neurological symptoms from your manipulation. And I would then routinely do now in this patient, a cranial nerve exam and sharp PIRSA every time, every day before I manipulate them as a routine. Is that okay? Now we've got 10 minutes or so to discuss this, and I think it's deserving of discussion. So what have you got for me? That came at you pretty fast, so you should have some questions for me.
So Jim,
Yeah,
with the sharp PIRSA with the patient with headache and dizziness and neck pain,
yeah.
are you looking for those symptoms to improve with the
No.
sharp PIRSA? Or
No, the sharp PIRSA is not a symptom reduction test. Okay. The sharp PIRSA is purely objective. You feel a glide when you shouldn't feel the glide. So when you push the head back, you're stabilizing C2. When they put the head forward, if there's an instability, C1 moves forward on C2. You stabilize the spinous process C2, push the head, the forehead backwards without extending it. And if you feel that slide, that's unstable. Now, if you want to see what that feels like, do not semiflex the neck. If you leave the neck in neutral and then do that glide, you'll feel some slippage. All right, that's what a positive test feels like. But if you flex them, that should take up all of the movement in a normal person without going right through it. So there's always going to be some translation forwards and backwards. But when you flex it, that translation should stop. So you can feel what a positive one feels like. The sharp PIRSA was originally, no, it's not true. The sharp PIRSA was misinterpreted by us for a very long time. And I did it as well. I wrote an article in Journal of Manual Manipulative Therapists arguing that the sharp PIRSA test doesn't work and it's dangerous and it's pointless because it was all about symptom reduction, which is really stupid if you think about it. If I get a patient to put their head forward and they don't get symptoms, is there any point in doing a sharp PIRSA test?
no,
No. Okay. So if I put their head forward and they get symptoms, is that the time to do a sharp PIRSA test?
no,
So when would you do the sharp PIRSA test? There's no indication for it if they got symptoms. If I have a patient put their arm head forward and I get pins and needles down the arms and legs, I get their head out of that position, call an ambulance, put a hard collar on them, and get them into an emergency room. I'm not going to screw about with that. Why would I? So try to differentiate where it's coming from. If you do the test and the sharp PIRSA is positive, that is, the symptoms go away, you're still going to send it to the emergency room. If the symptoms don't go away, you're still going to send it to the emergency room. There's no point in doing that test. And that's why I argued in this article. It makes no sense. But that's not what the sharp PIRSA is. The sharp, you can get this article now. JOSPT has it, I believe. It was very difficult to get. I eventually found it. It was written in 1961. But it isn't that. It's a feeling of a slippage. It's not a clunk test. You don't clunk this backwards and forwards. You feel it translate backwards. And that translation is a positive test. Now, the thing is, even based on sensitivity, it still makes no sense to do sharp PIRSA. No sense to do the anterior translation test. There's no evidence for the anterior translation test. None at all, other than clinical experience. And I've never seen one that's been that way. But the sharp PIRSA test will be positive at 3 millimeters and very positive at 4. Okay. Whereas to get symptoms in a normal size canal, you need 8 millimeters of migration to compress the cord enough that it will produce symptoms. So the sharp Purser test is at least twice as sensitive as that anterior translation test. Yes, you're trained to use best evidence in your exam. This is one area which I don't understand when nobody uses best evidence, which is the sharp Purser test. And it's certainly no more dangerous, although people argue this, it's no more dangerous to do the sharp Purser test than it is the anterior translation test. I'm asked them to put their head forward, and if that gets pins and needles, I say, stop it, get your head out of that position. Whereas I'll do a straight shear, I'm producing that, and I shouldn't be. I don't know how much force to apply to this, where I'm just going to stop doing damage. So use a sharp Purser, it's actually got evidence for it. It's actually more sensitive, even given what evidence we do have for the anterior shear test. There's no reason to use the anterior shear test at all. But it isn't a symptom reduction test.
I should probably go back and watch that video, huh?
Probably, yeah. Yeah,
All right. Thank
all
you.
right. Anything else?
Can you review the order of the testing to, once we were trying to rule out VBI and then feeling comfortable with moving forward with exam? Kind of
I'm going to
the-
do that. I'm going to do that on this. All right. I'll go through. I'll do it on diagrams and wordage. I'll do it again, and I'll bring it into a more condensed form. But first off, use your history to say, I'm not touching this patient. Okay, that's what the history is for. I'm not going to test this patient. I'm going to look at range of motion. This one is potentially VBI or a fracture, and it's leaving my office right now. Okay, you send it back to the doctor or to the emergency room in an ambulance or not in an ambulance, whichever way you feel about it, how urgent it is. But that's what the history is about. I'm not going to test this anymore. Having decided to test it, do the non-movement test first. We've already done the neuro. If we haven't, we can do the neuro now. And then do these non-movement stress tests and then get into moving the neck around. Okay, that's the order I do it. If there's any chance that this is a fracture, get them into a hard collar, get them into the emergency room. If it's a minor fracture where the C-spine rules have been breached and it hasn't been x-rayed, or it's low down and it's very localized, where you're not too concerned about it being an instability fracture that's going to threaten the patient's health, then you can do a bit more exam to give the physician more information. Okay. But I'll run that on a diagram for you, a flow chart, and you can see what it looks like. I'm pretty sure that we've done this on videos. And I'll get this done for you, all right?
It just means more now.
Yeah, possibly, yeah. Yeah.
Yeah, but this was a good summary of, if you look at spinal, like all these things, what are the safety considerations? And as you can see, there is a little different nuances for, different presentations or different differential diagnoses.
Yeah, there absolutely is. Your examination should not be routine. Your exam should be based on the context of patients bring in with them.
Mhm.
It should be a routine exam. Yeah, it's all contextual. Context is always king.
Yeah, that's why somebody requested and I go over the safety information, but I think this does it nicely because it puts it in the context of what you'll see in a patient and what you should be thinking about. I have this patient in front of me. This is what I whittled out these other differentials like you did with Drew. So what's the worst case? And okay, where am I with this? Am I comfortable with this or not in proceeding forward?
Yeah.
Many times you won't be. That patient, 4 weeks, even still with enough concern there, I'm not sure I'm manipulating something there unless it's obvious and I feel super comfortable, but I'm not sure I'm super comfortable if I have alternatives to improve that joint mobility.
Well, again, you probably would be comfortable if you knew that there was no major issue there.
Yeah.
When you got a joint that's causing a lot of pain, you'd probably manipulate it. But that comes with quality experience, and also your techniques are good enough that you know that you can do it without flaring them up like a lunatic.
Yeah.
Yeah. Yeah.
Right, and I'm with Dave on the time frame in this particular patient. After 4 weeks, I would wait at least another 2, based just on the healing time for the typical arterial tunica intima tearing, things like that.
No, I'm happy.
Um,
Honestly, if I'm comfortable, there is no. Look at the techniques we're using. Probably the best thing we do in this program is techniques that don't cause major displacements of the neck. I think we could probably manipulate a VBI patient, not know about it, and neither will the patient. The only problem comes is when you give them more range of movement and less. This is what happened to the Colorado Springs guy. He a very careful therapist as well, and he manipulated the lower neck, and the patient did have a VBI problem. It was in the upper neck, which he never manipulated, but he increased the range of motion. The patient turned their head and pop, off it went. So that's always a consideration. In the absence of dizziness and headaches, I'm not sure I would. I think it depends on if you know you've got a lot of inflammation present, then yeah, manipulation is not ideal for the patient. Usually, not always. So you're going to let that run its course, treat the inflammation, rest, and all the other stuff we do. But at some point, you're going to have to manipulate this. And 6 weeks, the problem is it's not the intramural tearing so much. That usually does get better in about 6 or 8 weeks. It's the thrombus that's left behind. And that thrombus stays there. So I remember a guy telling me that he was treating a patient for tennis elbow, didn't touch his neck. The guy walked in one day and he said, "Oh," he said, "Oh," like, he said, "What's the matter?" He said, "I was shaving." He said, "Something happened." He said, "I got a hot flush up my face, and then it felt like rain coming down my face, wetness." He said, "And I got dizzy. I can stop the dizziness by doing that." He had a VBI problem. And that was about a year earlier in a bus accident. When they looked at the histology, he survived it, but when they looked at the healing in the neck, it was a year earlier. But I take your point. I think you need to be really very experienced and good with the techniques before you start looking at doing this. On the other hand, you do get patients that have minor neck problems after an MVA that you can manipulate immediately. Yeah. I'll get this done and I'll get it out to you, okay? Okay, we're late.
Yeah,
All
good
right.
session, Jim.
Okay, take care all. Bye.